I'm Bobbi Fischer, and this is my Aesthetically Awkward Podcast, a show where we dive into all things aesthetics, health, wellness, entrepreneurship, and everything in between. This podcast is for informational and entertainment purposes only. It is not medical advice. Please consult your own healthcare provider before making any decisions in your personal health journey. Now let's get into it. Welcome back to the podcast. Today's episode is part of a hormone education series for women who want real answers about their bodies without feeling overwhelmed by the information. Today's episode is all about progesterone. Progesterone is mentioned a lot in hormone replacement therapy discussion, but it's not always explained clearly. It comes up in discussions around PMS, sleep issues, anxiety, infertility, cycle irregularities, or menopause. Many women leave appointments still unsure what it actually does or why it matters. If you haven't listened to the estrogen episode from last week yet, I highly encourage you to go back and start there. Estrogen and progesterone work together. Understanding estrogen first will make today's conversation a little more easy to understand. My goal is that by the end of today's episode, you understand a little better how progesterone works, how it changes throughout your life, what symptoms are common versus concerning, and how to talk to your provider in a way that leads to real care. Before we dive in, we're going to go behind the mic where I share one flex or one flop from the week, and I actually have one of each. My flex is that we've officially hired a second esthetician. She's going to be joining us next month, first doing her orientation on the administrative side of things, learning our software, our procedures, before seeing clients and patients in person, hopefully by early February. Growing a team is very exciting, but there's a lot of work that people don't see, especially if you're someone who has only worked for a large corporation or in corporate medicine or healthcare. Trying to build strong onboarding protocols, protecting our culture, making sure patient care stays consistent. I'm really proud about where we're headed and how we've grown as a team, and I'm very excited to bring this new provider on. My flop for the week is that this is actually the second time I've had to record this episode due to technical error. If you've ever thought you nailed something the first time and realized the audio didn't save or there was some sort of a glitch, I'm sure you can understand or appreciate how frustrating that is. We're just rolling with it. Honestly, the second take's usually better anyway. Let's get into progesterone. To understand progesterone, you need to understand how the menstrual cycle works. We did discuss this a little bit last week. We're going to recap it again this week. Progesterone levels are directly linked to whether or not ovulation is occurring. So menstrual cycle, day one of bleeding, that's when your period starts. During the first half of your menstrual cycle, your body is preparing to release an egg. Estrogen is the primary hormone during this phase. Estrogen helps rebuild the lining of the uterus after your period and supports the egg as it matures. Progesterone stays low during the first half of the cycle. Ovulation is the release of an egg from the ovary. In a typical 28-day cycle, ovulation occurs around day 14. Now, not everyone has a 28-day cycle, so ovulation may happen a little earlier or later. It's a helpful way to think about ovulation occurring about 2 weeks after your period starts and about 2 weeks before the next period is expected to start. After ovulation, the ovary shifts into producing progesterone. That marks the second half of the cycle, referred to as the luteal phase. Here, progesterone is stabilizing the uterine lining and it's preparing the body in case pregnancy occurs. Progesterone does far more than that, though. It also impacts your brain and your nervous system. It plays a direct role in the quality of sleep you get, in regulating anxiety and your stress response, and your emotional steadiness. That's why many women notice that the second half of their menstrual cycle usually feels a bit different. Sometimes you feel calmer, more clear. Sometimes you might feel more sensitive. Sometimes you might feel more tired. It's directly linked to those progesterone levels. After ovulation, your progesterone usually remains higher for about 10 to 14 days. If pregnancy does not occur, progesterone levels will decline. That decline triggers the uterine lining to shed, which becomes your next period. If ovulation doesn't occur at all, this pattern doesn't happen. Estrogen may still rise and may still fall, but progesterone doesn't follow its usual cyclical pattern. Let's talk about two other hormones that are directly linked to these levels: follicle stimulating hormone, or FSH, and luteinizing hormone, LH. These are made in the brain. Their job is to communicate with the ovaries. Early in the cycle, your FSH will rise, and that rise tells the ovaries to begin preparing the eggs for release. As those eggs mature, estrogen is produced. That estrogen rise helps rebuild the uterine lining, preparing the body for ovulation. Once the estrogen reaches a certain level, the brain responds by releasing a surge of LH. The LH surge is what triggers ovulation. Ovulation doesn't occur without that LH signal. Once ovulation happens, the ovary shifts from making estrogen into making progesterone. progesterone. The sequence matters. FSH helps prepare the egg, LH triggers ovulation triggers progesterone production. These hormones all work together as a system, not independently. We're going to talk a little bit about progesterone across the lifespan. So in adolescence, this system is still maturing. Ovulation is usually inconsistent in the first few years after a teenager's period begins. Teenagers may have bleeding without ovulation every cycle. Progesterone patterns can be uneven, which might explain heavy periods, acne, mood swings, anxiety, those emotional up and down roller coasters. It's very common early on. During the reproductive years, ovulation usually becomes more consistent, allowing progesterone to rise in the second half of the cycle. Ovulation is still sensitive to external factors: high stress, poor sleep, undereating, excessive exercise, illness. Certain medications can all disrupt ovulation. And when ovulation becomes inconsistent, progesterone changes, even if your periods are still happening. That's when women start to notice symptoms of PMS, irritability, anxiety, poor sleep, bloating, headaches, breast tenderness during the second half of their cycle. The symptoms aren't random. They reflect how progesterone is functioning within the body. When we discuss perimenopause, we are usually talking about women in their late 30s, early 40s, but it does vary. Women are born with a limited number of eggs, and over time, that supply naturally decreases. As the ovaries become less responsive, the brain increases the release of the follicle-stimulating hormone in an attempt to stimulate ovulation. As ovulation becomes less consistent, progesterone becomes inconsistent. Estrogen may still be produced, and it might be fluctuating, and that's why early perimenopause can feel so chaotic for so many women. Sleep disruption, new or worsening anxiety, mood changes, heavy or irregular periods, stronger PMS symptoms, reduced tolerance for stress. Sometimes they're dismissed or overlooked, but it is directly linked to physiological changes happening within your body. As perimenopause progresses, your luteinizing hormone surges become less predictable. Ovulation occurs less. Eventually, ovulation will stop altogether. When that happens, we're now moving into menopause. Menopause is defined as 12 consecutive months without a period. After menopause, the ovaries no longer respond to the follicle-stimulating hormone and luteinizing hormone the way they once did. And that's why we often use the follicle-stimulating hormone lab marker or biomarker to help confirm menopause. The high follicle-stimulating hormone itself doesn't cause symptoms. It's just a reflection of what the ovaries are doing. The symptoms women experience are due to the lower or more volatile levels of estrogen, as well as lower progesterone. Progesterone affects more than reproduction. It's influencing your sleep, your mood, stress response, breast tissue, your bone, your immune regulation, and your temperature regulation. And that's why symptoms persist well after your periods stop. And what can you do about it? Foundational support definitely matters. Making sure that you're addressing stress, sleep, nutrition to prevent worsening of your symptoms related to those progesterone and estrogen changes. Eating regular meals with adequate protein, stabilizing your blood sugar, getting consistent sleep, exercising appropriately to support your nervous system. Some women explore herbal remedies. Supplements do vary widely depending on their quality and their dosing. Make sure that you are under the guidance of a provider before starting any new supplements. Hormone therapy should be a clear evidence-based conversation. The Women's Health Initiative, published in the early 2000s, studied specific hormone formulations. The early reports from this study said that hormone therapy was unsafe. That message led to fear-mongering. The risk with hormone therapy depends on age, how long it's been since menopause, the type of hormone used, the dose, the route of administration, and that person's individual and family health history. Modern guidelines emphasize individualized care. Progesterone has two evidence-supported roles in hormone therapy. One is protecting the uterine lining in women who use systemic estrogen and still have a uterus. That means if you are taking any form of estrogen and your uterus is intact or you have not had a hysterectomy, you need to be taking some form of progesterone to protect your uterus. The second evidence-based symptom support in perimenopausal women is for vasomotor symptoms and sleep, night sweats. Synthetic progestins are chemically different from progesterone, and they interact differently with hormone receptors. Bioidentical progesterone, such as oral micronized progesterone, is chemically identical to the endogenous progesterone that your body produces. Randomized controlled trials and meta-analyses support micronized progesterone for uterine protection and sleep improvement, with observational data that suggests a more favorable breast safety profile compared with older synthetic progestins. And what that means is we see less risk of developing breast cancers in bioidentical versus synthetic progestin. There's more than just the oral route for bioidentical progesterone therapy. Oral is the most studied route. That dosing and the timing needs to be individualized. And the goal of hormone therapy is not to reverse aging. It's for symptom relief, health protection, and improved quality of life. That brings us into the unfiltered Q&A. I draw these questions directly from my Instagram stories and polls. If you want your questions featured, make sure you're following at Aesthetically Awkward Podcast and at Bobbi the MP _Luxla. Question I received last week after our estrogen episode is, I went through menopause around age 45 and my primary care doctor has since stopped my estrogen patch. I'm still having symptoms and they won't put me back on it. What can I do? So there's no rule that estrogen has to be stopped at a specific age or number of years after menopause, although it is widely stopped around 10 years after menopause. Current evidence supports individualized decision-making based on your symptoms, your health history, your family health history, and other comorbid risk factors. If you remain symptomatic and you're an appropriate candidate for therapy, it's reasonable to seek care from a provider with menopause-specific training. Have that discussion with your provider again, advocate for yourself, and ask for a referral or seek care from another provider. Progesterone changes throughout a woman's life. Those changes affect sleep, mood, stress tolerance, your overall well-being, not just reproduction. Understanding what's happening within your body gives you clarity and the language needed to have those discussions with your provider so you can participate in your care instead of feeling dismissed. Thanks for being here. I'll see you again next week.